Okay, let's unpack this. Today we're diving into, well, a really crucial and sometimes frustrating part of dealing with healthcare.
Mm-hmm.
How your insurance actually decides which prescription drugs it's going to cover and, when.
Yeah.
We're zeroing in on a specific practice insurers use that,
Yeah.
frankly, impacts millions.
Mhm.
Sometimes people don't even realize it's happening until, bam, it affects them directly.
Right. We're talking about step therapy, or you might hear it called fail first.
Still thirst. Yeah.
It's basically a mechanism built into a lot of health plans. It
Right.
means you, the patient, have to try certain drugs first, usually ones the insurer likes because they cost less.
Okay.
And you have to show those didn't work before the plan says okay to covering a different drug, even if that different drug was what your doctor wanted in the first place.
Wow. Okay, so we've got like a whole stack of sources for this deep dive: research papers, policy summaries, even some patient stories. And our goal here is really to cut through all that complexity. We want to understand the what, the why, the how of step therapy. Why do insurers even use it?
What's the real impact, right, on patients, on doctors?
Exactly. And what are policymakers trying to do about it, if anything?
Yeah.
And maybe how does it fit into this bigger picture of like healthcare costs and value?
Right. So at its core, fail first, it's really about keeping costs down,
Uh-huh.
guiding patients towards specific, usually cheaper medications before they'll okay the more expensive ones. It's the insurer's tool for managing drug spending.
And the rationale they give, at least based on what we read, is pretty much that cost containment.
Yeah.
They argue it helps control these, escalating drug prices and make sure people use effective but less pricey drugs first.
And it's not some obscure thing. It's really widespread. There was a review back in 2021 looked at 17 health plans,
Okay.
found step therapy was used in roughly 39% of their drug coverage policies. So pretty common.
Almost 40%.
Wow.
And we also saw this link to something called value-based insurance design, VBID.
Ah, yes. VBID.
It sounds complicated, but the idea seems to be about getting the most health benefit for the money spent, right? Optimizing outcomes versus cost.
Exactly. And the Affordable Care Act, the ACA, actually brought in some VBID ideas. Step therapy gets kind of positioned by its supporters as fitting into that.
How so?
Well, the idea is it encourages using drugs that are seen as high value, meaning they work well for their cost before moving to pricier options.
So VBID tries to align what you pay, like your copay,
Yeah.
with the value of the drug or service.
That's the goal. And step therapy is one way they try to financially nudge people toward those preferred, often cheaper first-line drugs.
Okay, but here's where it gets tricky, right?
Yeah.
Where it really hits patients. We have to talk about the human side of this, the impact we saw described.
Yeah, and this is critical. The potential negative effects, they're pretty significant. We're talking about delays in getting the right medication.
Delays.
Right. Which can, unfortunately, lead to diseases getting worse, more hospital visits, and just a real hit to someone's quality of life.
That's incredibly concerning. There was this poll, I think, by the PAN Foundation that really brought it home.
Oh, yeah, that poll.
It found 55%, over half of adults who had to go through step therapy, faced delays. And not just short delays, sometimes up to 11 weeks to get the medicine their doctor actually prescribed.
11 weeks! And think about what that means. The same poll, alarmingly, found 21% of those patients said they ended up in the ER because of the delay,
21% in the ER.
and 20% needed to be admitted to the hospital, again, directly linked to the delay caused by the step therapy protocol.
Wait, so the policy that's supposed to save money, it might actually be causing these super expensive ER visits and hospital stays later on.
That's the irony and a major point of contention. And the sources really emphasize how crucial getting the right medicine quickly is for certain conditions.
Which one specifically?
Well, patients with chronic diseases, rare diseases, they often feel this impact the hardest. Think about inflammatory bowel disease like Crohn's or colitis.
Okay.
If you delay getting on effective biologic drugs, symptoms can flare up badly, you can get serious complications, maybe even irreversible bowel damage down the road.
Irreversible. Wow.
Or multiple sclerosis. Waiting on those disease-modifying therapies, that delay can mean permanent damage to the nervous system.
And you mentioned rheumatoid arthritis too. Delays in getting biologics there, that can lead to joints being permanently deformed.
Exactly. And even things like breast cancer, The sources clearly state treatment delays mean lower survival rates.
Yeah.
It's that serious.
It's not just the life-threatening stuff either, is it? Like psoriasis was mentioned. Delays there can cost people time off work, time out of school.
Absolutely. And for mental health conditions like schizophrenia, if step therapy disrupts access to the right atypical antipsychotics, it can really destabilize someone's treatment.
There was that quote from an oncologist. It really stuck with me.
Which one was that?
Something like, you don't have the luxury to fail, because failing there can mean life-threatening or death.
Yeah, that cuts right to it, doesn't it? For some people, fail first isn't just an annoyance. It's genuinely dangerous.
And you see patient groups really pushing back hard on this.
Oh, definitely. They share these powerful personal stories like, we read about an ulcerative colitis patient whose delay led to needing their colon removed entirely. A colectomy.
Jeez.
Now, researchers point out, okay, these individual stories, they aren't necessarily what happens to everyone, but they absolutely highlight the potential worst-case outcomes. They're stark warnings.
So this patient impact, it obviously lands right in the doctor's lap.
Yeah.
How does step therapy affect them and that whole doctor-patient relationship?
Yeah, that's a huge piece of this. A lot of doctors really object, quite strongly sometimes.
Why specifically?
They feel it overrides their medical judgment. You know, they've examined the patient, they know the history, they've looked at the evidence,
Right.
and they believe a certain drug is best. But then this insurance protocol, often based mainly on cost, steps in and says, nope, try this other thing first. It undermines that individualized care.
We saw that survey from the ABIM, American Board of Internal Medicine. It found most doctors kind of get the idea of managing costs, but they really don't like how step therapy is actually being done.
Exactly. And interestingly, specialists, oncologists, endocrinologists, cardiologists, they were even more likely to push back against these mandates than, say, general practitioners, maybe because they see the immediate risks more clearly in their fields.
That makes sense. And then there's just the sheer hassle factor, right? The administrative
Oh,
burden.
it's massive. The sources talk about doctors and their staff spending hours, just hours on appeals, digging up documents, doing these peer-to-peer calls with insurance company doctors.
And those insurance doctors might not even be specialists in the patient's condition.
Precisely, which adds to the frustration. And all that time. That's time not spent caring for patients. The AMA has pointed out it contributes to doctor burnout, too.
So it really feels like step therapy clashes with some core medical ideals.
It really does. You think about health equity, about patient-centered care.
Yeah.
And this kind of one-size-fits-all fail-first approach. It might totally ignore a patient's unique situation, their history, even practical things like, can they actually get to multiple infusion appointments if they have transportation issues?
Right. It feels like the opposite of precision medicine, too, which is all about tailoring treatment to the individual, their genetics, their environment.
Instead of just picking based on averages or, which drug got the insurer the best deal.
Okay, so with all these problems for patients and doctors, it makes sense that policymakers are getting involved.
Definitely. There's been a lot of action, especially at the state level.
How many states have done something?
The sources said, as of 2024, at least 36 states have put laws or rules in place to try and limit step therapy, put some guardrails around it, add patient protections.
36, that sounds like a lot. But there's a catch.
Right? A huge catch. State laws generally do not apply to most employer health plans, the ones that are self-funded.
Self-funded. Okay, what does that mean exactly, and how common is it?
It means the employer pays the healthcare claims directly rather than buying a fully insured policy, and it's very common. KFF data showed about 65% of people with employer coverage are in these plans.
Like 5%.
And for bigger companies, it's even higher, like 83%.
So state laws trying to regulate step therapy just miss most people who get insurance through their job.
Pretty much, because those self-funded plans fall under a federal law called ERISA, Employee Retirement Income Security Act.
Ah, ERISA. Heard of it.
And ERISA generally overrides or preempts state insurance laws. So you have this big gap where state protections just don't apply.
Okay, so if state laws can't fix it for most people, what about the federal level?
That's where the Safe Step Act comes in. It's federal legislation that's been proposed specifically to target these group health plans, including the ERISA ones, to fill that gap.
The Safe Step Act, what would it actually do?
The main thing is it would create a clear and, importantly, fast process for patients and doctors to ask for an exception to a step therapy rule.
Fast how?
It would require the health plan to give an answer within 72 hours for standard requests, or just 24 hours if delaying treatment could put the patient's life at risk.
Okay, 24 hours in urgent cases. That's a big difference. And what kind of situations would qualify for an exception?
The bill lays out specific circumstances where the plan must grant an exception. Like, number one, if you've already tried the required drug and it didn't work for you before,
Makes sense. What else?
or if the required drug is basically expected to be ineffective for you and waiting would cause serious or irreversible harm.
Okay.
Also, if the required drug itself would actually harm you, maybe it's contraindicated or you're likely to have a bad reaction. Another one, if taking the required drug would stop you from working or doing, basic daily activities.
Practical impact.
And finally, if you're already stable on a medication and it's been covered by your insurance before, either your current or a recent previous plan, they shouldn't make you switch off something that's working.
Those seem like pretty reasonable exceptions. Is this bill getting much support?
Yeah, actually, the sources highlighted it has support from both Democrats and Republicans in Congress,
Bipartisan, okay.
and it's backed by hundreds of patient groups and doctor associations. Seems like there's broad agreement that something needs to be done.
And tied into this, there was also talk about needing more transparency, especially around PBMs.
Yes, pharmacy benefit managers, big players behind the scenes.
They manage the drug benefits for insurers, right? Negotiate prices.
Exactly. And then negotiate rebates from drug makers. So the concern is, are step therapy lists sometimes designed to push patients toward drugs that give the PBM or insurer a bigger rebate rather than what's truly the best clinical first choice?
Is there evidence of that?
Well, proponents of more transparency certainly raise that concern. And given that just 3 big PBMs controlled something like 80% of all prescription claims in the U.S. in 2021,
80%.
their influence is undeniable. So calls for more openness about how these lists are made seem pretty understandable.
Okay, so let's zoom out for a second. All this talk about step therapy, cost control, exceptions, it fits back into that bigger idea we touched on earlier, VBID.
Right, value-based insurance design. Let's circle back to that. The sources frame it as a demand-side approach.
Meaning it tries to influence patient choices.
Yeah, through money, basically. Your
Yeah.
co-pays, your deductibles, even premiums. They structure them to encourage you to use services or drugs they deem high value,
Where the benefit justifies the cost.
and discourage things considered low value, where maybe the benefit isn't worth the price tag.
And the goal is better quality healthcare, lower overall costs, guided by this idea of clinical nuance.
That's the term they use, yeah. Recognizing that value isn't static. It depends on the patient, the situation, the timing.
Did the sources give examples of VBID in action?
They did some interesting historical ones, like Pitney Bowes, the company, years ago lowered copays for asthma and diabetes meds for its employees.
And what happened?
They found people took their meds more consistently, had fewer complications, and it actually saved the company money overall.
Fewer complications means fewer expensive problems later.
Exactly. Or the Mayo Clinic shifted costs away from specialty care and imaging towards more primary and preventive care.
And governments have tried it too.
Yeah, Connecticut had a program in its state employee plan focused on increasing use of certain high-value services. It seemed to improve medication adherence and cut down on ER visits.
Okay.
And Michigan used it in their Medicaid expansion, waiving copays for things meant to prevent chronic diseases from getting worse.
So the research generally suggests that if you make high-value care cheaper for patients,
They're more likely to use it, stick with it, and yeah, potentially it can save money in the long run by keeping people healthier.
Okay, so let's bring this all home. All this complexity, step therapy, VBID, ERISA, state laws, federal bills,
Right.
what does it actually mean for you, the listener?
Well, first off, chances are pretty high you get your insurance through work. Employer plans cover almost 153 million non-elderly people in the U.S.
And remember that big gap, most of those people, likely including you, are in self-funded plans where state step therapy laws probably don't apply.
Right. Now, layer that onto the fact that healthcare costs keep climbing. Average family premiums jumped 7% just last year, faster than wages grew, faster than inflation.
Oof, and deductibles too, they're not small.
Not at all. Average single deductible was over $1,700, higher at smaller companies. Lots of people face deductibles of $2,000 or even more before insurance really kicks in significantly.
And employers know this is tough. They report that affordability, especially the cost-sharing part, is a huge worry for their employees.
So things like step therapy or prior authorization, another thing employers worry about for their workers. These aren't just abstract policies. They're part of the financial reality you have to navigate to get care.
So what happens if you run into this?
Yeah.
Your doctor prescribes something and the insurance says no, you have to try something else first.
Okay, so according to the sources, that's officially called a denial of service. But you do have recourse. Your first step is usually an internal appeal with your health plan.
You challenge their decision directly.
Right. And if they still say no, for most plans now, these non-grandfathered ones under the ACA, you have the right to an external review.
External review.
Yeah, an independent third party, someone not connected to the insurance company or sometimes the state, reviews your case and makes a binding decision.
That sounds important. Is there anything people should do proactively?
Absolutely. The sources stressed keeping really detailed notes.
Like what?
Everything. Dates of doctor visits, what was discussed, names of people you talked to at the insurance company, dates of calls, reference numbers. Keep copies of all letters back and forth.
Gotcha. Documentation is key for appeals.
Vital. It makes building your case much, much easier.
Okay, so wrapping up this deep dive, it feels like the sources really lay out this core conflict, this tension.
Yeah, it's pretty clear. On one side, you have this very understandable goal, trying to control healthcare costs that just keep rising. And tools like step therapy are one way insurers try to do that.
But on the other side,
You have the very real potential for these same tools to delay treatment people really need, to actually cause harm, and to create just a massive amount of hassle and stress for patients and their doctors.
and we're seeing policy efforts like the Safe Step Act at the federal level,
Yeah.
trying to thread that needle, right?
Exactly, trying to find a better balance. How do we protect access to necessary care quickly, while still allowing cost management tools to be used, but only when it's safe and truly makes sense clinically?
Which leaves us with a final thought, maybe something for you to chew on.
Yeah.
Given everything we've seen, especially the evidence that delaying the right treatment can lead to worse health, more complications, maybe even higher costs down the line, how do we actually get health plans and policymakers to think about value, not just as the sticker price of a drug today, but as the long-term health, the function, the overall well-being of the actual person needing that care? How do we make that the real measure of value?